episode of Trac and Pac.
Thank you, Chairman, for my introduction. So, first of all, I apologize for the change of my title of this presentation. So today I will talk about the difference between the robot and the laparoscopic surgery in terms of the liver resection, especially introducing our new liver transection method, Trac and Pac, which can also be used for the anatomical resection and using the Marian forceps. So as you all know that there are three major there's a major difference between the robot and lap. So now we will show you the three differences when performing the liver resection. One is the wide range of movement and the stability of the robotic instrument. Second is that the quality of the ICG scope is different, and the console surgeon cannot use the CUSA. And I think everyone knows the technique that are more necessary when performing the anatomical resection compared to the local resection. These include the inflow control, the outflow control, liver mobilization, the appropriate guidance of the liver transection plane, and the parenchymal transection with exposure of the intersectional vein. The first three are definitely easier to perform with a robot than with a laparoscope, because the robot wide range of movement and the stability of the robotic instruments help us very much. So you can see the liver mobilization, isolation around the IVC and the major hepatic vein, to inflow control technique, including the individual ligation and the glycine ligation. All of these can be carried out, of course, in the laparoscopic approach, but robotic surgery is the easier. Next is about the ICG fluorescence. ICG navigation has improved the quality of the liver surgery. The recognition of boundaries within the liver parenchyma using the ICG is a great information that is not available elsewhere. It is also possible to obtain biliary tract information. ICG system in Da Vinci is still at lower quality than the laparoscopic scope. It is not possible to override natural light in the ICG. It is also not possible to change the intensity of the ICG. Firefly can visualize bile ducts, but the quality is still inferior to that of the laparoscopic scope. However, this will be improved by upgrading the equipment in the future, and moreover, ICG navigation is not necessarily required in many cases. The last issue is about the parenchymal transection. So in the end, I think the biggest challenge in the robotic liver resection is achieving an ideal liver transection. So in European survey, the liver transection method in the robotic setting varied, and many surgeons were hoping for the arrival of the robotic CUSA. So I guess that these surgeons probably prefer to use the CUSA in the laparoscopic approach. Ideally, we would like to perform the liver transection with the CUSA sensation. The term CUSA sensation has been replaced with the following conditions, I think, with keeping the surgical field dry by preventing bleeding, quickly stopping bleeding by using the section, and with excavating the vessels, with exposing the hepatic vein, and with efficiently at an acceptable speed. In present, there is no DV CUSA, so we developed a method that uses Marian forceps to achieve this sensation. It is called the Trac and Pac method. Today I will introduce this. So the Trac and Pac method is a safe and effective way of parenchymal transection in robotic hepatectomy. Trac is an abbreviation of traction, and the Pac, which is named after Pac-Man. This method becomes even more useful with splash, which is the action of applying a saline solution to the transection surface. So first, I will start explain the traction. The traction is the most critical part of this method. It is not the action of the right hand that is a key point of the parenchymal dissection, but only the tension in the liver created by the left hand. Initially, the traction of the suture or the pressure of the third arm stabilize the field of view and provide surgical exposure. Then apply tension with the left arm to the parenchyma to be dissected. In this setting, parenchyma is naturally dissected by light stimulation with the Marian forceps. Under insufficient tension, the parenchyma is not going to be separated, but just going to be crushed by the motion of the Marian forceps, which eventually result in the necessary hemorrhage from the deep point or the invisible site. In the Trac and Pac method, we pull outward the cut surface of the liver parenchyma by the left arm. Under sufficient tension, parenchyma is going to be separated by the light touch or the small motion of the Marian forceps. The second motion of the Trac and Pac method is the motion of the right hand. We mainly use Pac motion, a motion of closing and opening the forceps combined with a bipolar self-coagulation for parenchymal dissection. Never tear tissue because the tearing leads to a necessary hemorrhage. Additionally, sweeping, the motion of tracing the cut surface gently or peeling, the basic way of dissection, are also effective for the motion of the right arm. This is a video of the right hepatectomy for the patient with normal liver. The first point, probably one of the most important points, is to create a basic position by the traction of the suture, then pull outward the cut surface of the liver parenchyma by the left arm and apply sufficient tension. This is a thing in the segment 5. Bipolar self-coagulation is set up to the right arm Marian forceps, and it is activated approximately once for every 2 Pac motions. The right arm Marian forceps touches the liver parenchyma gently and applies Pac motion, which means just closing and opening the forceps. Under sufficient tension, parenchyma is going to be separated by the light touch or small motion of the Marian forceps. This is the middle hepatic vein. The right arm Marian also sweep or peel the liver parenchyma. These gentle motions crush the liver parenchyma not only steadily but also effectively under sufficient tension. Dissect the liver parenchyma between the middle hepatic vein and the right glycinium pedicle. Then encircle the right glycinium pedicle, and after transection of the right portal vein and the right hepatic artery separately, dissected it by the staple. So by keeping the appropriate surgical exposure and sufficient tension, we complete this parenchyma dissection of the right lobectomy safely. This is a comparison between the clamp and crush method and the Trac and Pac method during the same operation. In the clamp and crush method, we clamp liver parenchyma deeper than the Trac and Pac method. This occasionally results in a necessary hemorrhage from the invisible site, which we often find difficult to cauterize. Additionally, in the clamp and crush method, the burn tissue tends to be attached to the forceps, while it is rare in the Trac and Pac method. It is the splash that makes a difference. Splash is the third point of the Trac and Pac method. The point is to create a clear stream of saline solution when hemorrhage occurs, to identify the hemorrhage site precisely and cauterize the hemorrhage site in an adequate amount of water. We need to create a clear stream of saline solution. Hemorrhage need to be stopped quickly without making burn tissue. However, cauterization in the blood or dry surgical view without water will lead to burn tissue attached to the forceps. So to avoid the creation of burn tissue And to identify the hemorrhage site precisely, we need an adequate amount of saline solution by bedside surgery. ASAC is a polyurethane sponge to which continuous suction is attached. We used to apply the gauze without the function of suction. However, this method is not enough to realize the ideal parenchymal dissection. ASAC is a useful device with two different features at the same time. The first point is the continuous section to create surgical field dry. And the second point is the traction of the liver parenchyma. The flat shape and the moderate amount of surface friction help surgeon to create the surgical view. The Trac and Pac method is also useful for patients with liver cirrhosis. This is a case of hepatocellular carcinoma with moderate fibrosis, stage 4 liver cirrhosis. So I inserted the left hepatic vein and we completed the left lobectomy safely. Here we will also show the video of left hepatectomy. First, we create the basic position by suture. We apply an attraction with ASAC on the left hand. So we have found the peripheral middle hepatic vein, so we will follow this. To show this technique, we have not edited the video as much as possible. Now, so we are adjusting the basic position to cut the lower part. So there is a sound. You can hear the bipolar activation of the meridional forceps with a beep sound. The assistant sprays saline as appropriate. The purpose of this motion is to moisten the traction plane to remove blood during the activation and make a bleeding point clear. As you can see, the Pac motion is performed without moving the forceps and in a fixed position. The liver is gradually broken up by both the open and the closed motion of the meridionum. It's never grasped and pulled. It's similar to gradually breaking up the parenchyma with CUSA. The basic position has been changed again. The first Pac motion has no bipolar output. You can see how the liver is being broken up by the traction force of ASAC, like CUSA. The liver parenchyma around the hepatic vein is being broken up little by little. Only the top tip of the meridionum is being used. Also, because it is being used after the saline, only the minimum amount of the burn tissue is attached to the top. So with traction, the parenchyma is separated by the Pac manipulation and the bipolar output. So now the before is isolated. We continue to dissect the liver along the middle hepatic vein. Peeling and sweeping the meridional forceps is effective for exposing the hepatic veins. We use Pac motion sometimes with bipolar activation and sometimes no activation. The liver divided by applying traction and stimulating it with Pac, sweep, peel by meridional forceps. So we remove the fluid as needed with an ASAC. We carefully remove the parenchyma around the hepatic vein. This is very much similar to the operation by CUSA. So you can see the another before. So once again, Pac motion does not tear the parenchyma. In the Trac and Pac method, the vessels remain in the crushed parenchyma. However, the Trac and Pac method, the vessels are found at the end of the broken parenchyma. You need to change your mind. So we have found the last before here. So we will excavate this in the same way as CUSA. So when contracting the parenchyma with bipolar, splash saline without the burn tissue. So we can find the last before and transecting. So after transecting this vein, so the transaction is complete after the stapling of the left hepatic vein. So finally, we compare the surgical results between the robotic hemihepatectomy with Trac and Pac method and the laparoscopic hemihepatectomy with CUSA. We have 23 robotic hemihepatectomy, including the 13 right and 10 left. First, in terms of the right hemihepatectomy, there is no difference between the robot and the lap. In terms of the total surgery time, blood loss, number of Pringles, and the Pringle time. We compare the operation time for each technique because it takes time to roll in, so the time from the start to manipulation was longer for the robot at the 25 minutes. On the other hand, the liver mobilization time with the robot was shortened to the 25 minutes. The inflow control and outflow control were almost the same. And the time for parenchymal transection was almost the same. Left hemihepatectomy was similar to the result of the right. There is no difference in terms of the surgery time, blood loss, number of Pringles, and Pringle time. Similar to the right, we need time to roll in. However, the time taken in the liver parenchymal transection was same as both groups. So in conclusion, we introduced a Trac and Pac method that can perform the high-quality liver resection in comparable time to lap CUSA. Thank you for your attention.
Thank you very much, Dr.